Hi, and I'd just like to welcome you all to this webinar. My name's Harry Jerram. I'm a consultant at Moorfields in the Glaucoma Service, and um, this is really to celebrate World Glaucoma Week, and it's been organised by the IAPB, which is the International Agency for the Prevention of Blindness, and they've been partnering with international organisations and experts in glaucoma care to really draw a spotlight on this condition, which is the third leading cause of worldwide blindness. And this is one of many events during the week, which is just going to put the focus back on glaucoma. Before I introduce our two speakers today, I'm just going to read out some basics of housekeeping about how the webinar is going to work. We have made it such that the microphones are all muted apart from the speakers, because this will just give us a better sound quality. We do really want this to be interactive and for participants to really have the chance to ask questions during the question and answer session and also at the end. So if you do have any questions, please do type them into the chat box, which is on the right hand side of your screen, and we'll pick those up and bring those up at the appropriate time. And please post questions either during the presentations or after the presentations. You know, as soon as the question comes into your mind, please put that up. If you also have any technical difficulties, for example, with sound, just put a message in the chat box and our team can try and resolve that for you. Just in terms of general computers, it's a good idea to try and close down all other web applications just to improve the sound quality. And if you have headphones, that will probably make it a bit better too. We are recording this webinar and it will be uploaded onto the IAPB website, and we will send the link round in a few days' time. And finally, at the end of the webinar, we'll be sending you for a survey just for your feedback to see what you enjoyed and see how we can improve things in the future. So it's my pleasure to introduce our first speaker, who is Professor Augusto Azora Blanco. Augusto is a professor of ophthalmology at Queen's University in Belfast. He's a member of the editorial board of Cochrane Eyes and Visions, Eye, and the Journal of Glaucoma, and he's the co-chair of the European Glaucoma Society Guidelines Committee, and has been the chief investigator of several high-profile, publicly funded trials, most notably the EAGLE study, which I'm sure you've all heard of. Now, Augusto is going to be discussing patient-centered innovations that may help improve glaucoma monitoring, and also touch on new models of delivering glaucoma care. So over to you, Augusto.
Thank you very much. Good morning, everybody. Can you hear me okay? I guess that's a yes. So we're going to talk about home monitoring for glaucoma, and from a European perspective, I guess. In Europe, glaucoma is the second leading cause of blindness, and this is Glaucoma Week, so it's very pertinent that we are having this seminar, and I would like to thank the IAPB to facilitate this conversation. So this is, the outline of my presentation, which will be about less than 20 minutes, and we'll have time for discussion. I'll just a brief introduction why we need better models of glaucoma care, more efficient, and then we're going to discuss, several possibilities that are at the moment being used by different healthcare providers, and talking about telemedicine, virtual clinics, and at the end we'll cover the key aspect of this presentation about home monitoring. This is the future, but there is also already some current initiatives in this area. So why do we need more efficient models of care? Well, mainly because of our aging population, and there are some estimates that, again, in one generation we're going to have a double of number of visually impaired people, particularly in Europe, from macular degeneration and glaucoma. And again, this is in one generation, the glaucoma prevalence will nearly double, and of course that will put a huge stress in healthcare providers, and this is again because of we are living longer. And of course, also there are also aspects about we are detecting glaucoma a bit better than we used to. So again, we have to plan, because at the moment, even at the moment, we are struggling to keep with the demand. Apologies because this is a very British orientated perspective, but I think that if you think about the UK being a wealthy, a rich country, and we are again we're struggling to provide glaucoma care to people with diagnosed glaucoma in our health services. And there are several reports, and the last one was from January 2020, and the other one is from a couple of years ago. Essentially, what is happening here that, again, because we don't have sufficient capacity, people are suffering harm, and there are a few cases that people that went blind because they didn't have enough follow-up attention to follow-up of their condition. And this is, of course, glaucoma is a leading problem because there are a lot of resources now, and fairly enough, to deal with, let's say, wet macular degeneration, but glaucoma in a way may be a Cinderella of monitoring people with this condition in our healthcare system. So what are possible options to improve efficiency? And again, I think this is an European-wide problem. And again, in the UK, we have an expanded role of optometrists, particularly hospital optometrists. And I'm aware this is unique, but certainly let's think about the third world and the low to middle income countries where nurses and other healthcare professionals are having an increasing and important role in delivering healthcare, and specifically about eye care. But again, I'm aware that this is probably a very UK, center solution. So we're going to talk about telemedicine, virtual clinics, and also home monitoring. So what about telemedicine, or teleophthalmology, or teleglaucoma? Again, there are a few specialties, and these specialties that are being used in telemedicine, the common characteristics that they use a lot of imaging information, about radiology, pathology, and dermatology. And ophthalmology, we are becoming more and more like radiologists. What I'm trying to say is that the clinical examination face-to-face is less important than it was a generation ago, and we are increasingly relying, let's say, in OCT or images, and that's a suitable way of delivering healthcare. We have, tests, and the need for face-to-face consultation is perhaps decreasing. And of course, telemedicine is about providing medical diagnosis and management decisions when the patient is far away from, the specialist. And this is particularly useful, of course, for rural population. But again, in any country, there will be a large, widespread of people with glaucoma and hospitalized services. Departments tend to be concentrated in urban regions. So this is, again, a potential solution for some of these challenges. And of course, this is not new. And one of the pioneers was our colleague Anya Toulon in, linking the glaucoma screening with diabetes screening, diabetic retinopathy screening. And again, these models of combining, chronic eye diseases makes a lot of sense. So there are some perceived benefits. If you think about teleophthalmology, from the patient's perspective, they don't need to travel to the hospitalized service in the city. Again, particularly think about rural populations. And from the point of view of the hospitalized service, there are also some potential benefits, because then, this potentially is a more efficient way of reviewing information and only, offering specialist advice to those with more severe conditions. Again, I would like to highlight, we all know the majority of people with glaucoma are going to do well. They have mild disease. It's only a minority of people that really have progressive disease or advanced glaucoma, and those are the ones that require most of our resources. There are some patients' satisfaction surveys regarding teleophthalmology, and here the challenge again is they don't see a specialist, they see a technician or a nurse, and by far the majority of patients are satisfied with these solutions of providing healthcare close to home. And again, this is also a formal evaluation about the efficiency or cost effectiveness of such a teleophthalmology, teleglaucoma screening or remote diagnosis. Again, these problems about, we don't know. I mean, the surveys tend to be bias assessments. I think that if you ask patients, what do you prefer, to have a specialist or a technician taking pictures? Perhaps some of them may prefer the glaucoma specialist, but again, you have to balance that with the availability of resources. If you think about teleophthalmology, and I'm going to ask you to reflect, because teleophthalmology requirements, this slide and this outline is very much applicable to the home monitoring. So I don't want to repeat myself, but again, if you're thinking about home monitoring glaucoma with a tablet to control visual fields, or you have a self-tonometer, you'll need to think about the hardware, the software, how you're going to communicate the results, and again, who is going to interpret the results. In this case, teleophthalmology is also the technicians or nurses who are going to acquire the images, but in home, and if you're thinking about home monitoring, you need to think about how and who is going to interpret the results that are coming from the patients. So teleophthalmology and home monitoring have very similar. So again, teleophthalmology hardware, of course, you need equipment necessary to conduct your key examinations. Electronic records and software, I think they are particularly useful when you're dealing, again, with trying to keep the data. I think that in some countries at least, there are still written notes. I think that is more and more healthcare providers and countries are using electronic records, and it's just to to emphasize how important this is. Difficult to quantify, but trying to implement teleophthalmology or teleglaucoma or with paper notes is just adds a great level and different level of difficulties. And again, communication, because the data protection, and again, that's also part of a European-wide regulation. It's very important to assess with your data protection officer in your institution about how you're going to manage this transmission of data. I think that there's a question mark whether it's just using a non-institutional email address and a PDF would be acceptable. So again, just look out for that particular issues. Now, one of the advantages about the teleophthalmology, and that would be also the same for home monitoring, is that glaucoma, you don't need to have real life consultation. Again, you can have a remote data acquisition, either in a peripheral clinic or a remote family doctor practice or at home, and you don't need to answer and provide feedback because it's not an urgent condition. So that, again, that's useful to manage the flow of information and also the decision making. And then, again, just to reflect, there are many challenges if you're trying to implement any type of change will have challenges. And some of the challenges are, again, regarding management or our behavior, and how we as doctors are very reluctant, many of us, to change our practice. And just if you're trying to implement a new model of care, you need to be aware of these potential difficulties. Just a very brief note, a very brief comment about virtual clinics. And this, again, apologies if this is perhaps a bit UK NHS centered, but in our context, this there is an increasing use of virtual clinics for managing chronic eye conditions, and I'm particularly talking about glaucoma, but also about diabetic retinopathy and macular degeneration. And again, essentially, what we are doing with the virtual clinics is that the patients attend the hospitalized service or the department. They get in glaucoma, they get the pressure check by a nurse. They have the visual field testing, and they have an imaging test. Typically, I'll take these pictures and or OCT, and then the patients go home, and then we, a glaucoma expert, we review the information a few days later, and then we make a decision. And this is a valid and very efficient system for the vast majority of glaucomas. Again, we are not talking about people with very severe disease, which are the minority of post-operative changes. But if you think about management of ocular hypertension or mild glaucoma, which is the majority of our clinics, again, this is a valid way of providing care. And again, it's very popular. I think that there is, I would say, about a majority of retina clinics and retina patients are managed with virtual clinics, and glaucoma is an increasing way of, again, managing people with this condition. There is some applications. This is, again, Moorfields is using, and Harry will confirm, is using this model, and is expanding. And of course, Moorfields has an influence in the UK and further beyond, and that's why, you know, more and more people are using this virtual clinic model. And of course, if you are going to think about using the virtual clinic, perhaps it's useful to read and be aware of this publication. This was a consensus based among different stakeholders, particularly experts in glaucoma. We tried to suggest what you need and what's the ideal situation regarding, you know, type of patients may be suitable, and again, certainly people with mild disease, ocular hypertension, and then what type of equipment might be acceptable to take the test for glaucoma. So that could be particularly useful. But I cannot stress enough the efficiency. In a couple of hours, I can go over 40 or 50 patients doing a virtual clinic. And of course, in a face-to-face in 2 hours, you know, I would struggle to see 10, because of course people, I mean, there is a difference, and again, there is an issue about patients may want to have, you know, direct consultation, at least sometimes with the ophthalmologist, but from the point of view of efficiency, and again, patients tend to accept this model of care if they have enough information about the reasons and the availability of a doctor if needed. For virtual clinics, again, I mentioned that before, for teleophthalmology, having an electronic medical record is essential. And here you see in the slide, you know, in the top of the slide, you can see the MD and the visual field. And then in the bottom part of the slide, you can have you can see the intraocular pressure near the green shade, so that intraocular pressure, you know, is within, you know, that green is highlighting between 8 and 21. And then these dots are, you know, when you are changing in, making some changes in management. And of course, you can track down the medications the patient has. So electronic records are particularly useful if they are designed for ophthalmology use and for our glaucoma use. And last but not least, we'll talk a little bit about home monitoring. And this is certainly the future. I don't have any doubt in one generation, our model will not be, you know, it's so inefficient. You know, you think about it, patients attending the eye clinic, you know, 2 or 3 times a year, having only one single intraocular pressure test, you know, only 2 or 3 times a year, a few visual fields. In many places, there is not possible to do a frequent visual field testing. And the technology is already here. I mean, there are challenges, and I'm going to review this, but I think this home monitoring will certainly potentially improve the quality of care, and also, you know, decrease the pressure, the challenges to deliver in the hospitalized services. And we are using home monitoring for high blood pressure, certainly for diabetics, and why not for glaucoma? The technology is here, and there are many groups, for example, working on virtual reality goggles. Again, we need a bit more research about how they work in real life. Perhaps the more advanced technology with more clinical use is the Melbourne rapid test. This is a tablet-based visual field technology that is commercially available, and I don't have any conflict of interest, but this technology is more mature. But again, there is no reason why other similar technologies could not work in this regard. There are some publications. Still, it's a bit early to see how this works in real life. I think we need a bit more research trials, but I think that I believe this is going to be with us in a few years. And of course, there's home tonometry. I guess this is the most popular model. This is a review article looking at comparisons between the home tonometer and the Goldman tonometer, and the home, of course, done by patients. And of course, there is a bit of variability, but the beauty of home tonometry is that you can test more frequently. You can acquire more data, and then again, we are using this occasionally now, but I just wonder whether this will be increasingly used for more patients in the future. There are some challenges. In one of them, of course, the technology is expensive, and all these gadgets, particularly home tonometer, is not cheap. And of course, perhaps the elderly population, may have some challenges if they are not technology savvy. But of course, you can always rely, on a carer or a grandchild or a granddaughter. There are again challenges about communication, sending the results of the test, interpretation. This has to be all careful consideration, and also again patients' preferences always need to be taken into account. And I think I'm going to finish now. Thank you again for this opportunity. Thank you again, Rachel and the IAPB team, and thank you, Harry, and all of you for your attention.
Great, thank you so much, Augusto. Now, I forgot to at the beginning. I was just going to put a poll up, so I'm just going to do that now, just to get your initial feeling. Well, your feeling now, having heard Augusto. What's your initial? If you could just give us a quick straw poll. What's your initial reaction to the idea of home field monitoring? And we'll just put this up. So, Augusto, I think you've sold to the audience. That's pretty impressive. And one more, just the take on home pressure monitoring, because I know within glaucoma specialists this has been a controversial topic on occasions. So just let us know what you think. What's your initial reaction to the idea of home pressure monitoring? Okay, that's great. I'll just put this up. So again, pretty overwhelmingly positive, but with some reservations. Now, so for all the other attendees, please, if you have any questions or issues you want to us to address, please do put those up on the in the chat box. Augusto, it's interesting the concept of telemedicine. Across the world, I think there has been some progress. What do you think? I think about the work that the team that have developed the PEEK devices have worked with in Africa, because I think that's helped with more adherence to appointments and attendance to clinics, which in my practice in London is a real problem if patients not coming to clinic. And I think one thing apart from monitoring the glaucoma is actually just the use of technology to remind people to come to clinics. What are your thoughts on that?
Yes, well, absolutely. I mean, thinking from a global perspective, and the work the IAPB is doing, and it's very relevant. And the PEEK was initially thought about helping low to middle income countries. And I think that we cannot emphasize enough the role of technology to access remote locations, underprivileged locations. So yes, I think that yes, having a mobile phone that, for example, in Africa, everybody has a mobile phone nowadays, and to have a healthcare intervention there, so people can have the diagnosis of some preventable problems. I think that's very exciting. Of course, if you think about the challenges of delivering glaucoma care, because one thing is diagnosing, as PEEK is designed to facilitate this initial this testing. But of course, delivering glaucoma care is another challenge that I mean, we don't need to go there. The IAPB is organizing regular sessions about how best to deal with these issues. But yes, and from the point of view of yes, teleophthalmology and using technology to facilitate closer access to care, I think that, as you say, Harry, people compliance issues or not attending, that's a significant problem. In some tends to be more prevalent in people with lower socioeconomic backgrounds. So whatever we can do to facilitate our provision of care, it's only good, and technology will help a long way.
And just going back to technology, I just wonder whether you what are your thoughts on whether this is an issue that can be implemented in the current generation, or do you think this is something that we should work on for the next generation? I'm just thinking about elderly patients who may not be so technology savvy, and really, the access to, I guess, internet that would be required to implement such things. And certainly in the UK, the cost of the technology in the context of reducing tariffs to see patients, is this something that, what could we do, and what could group organizations like the IAPB do to try to make this a reality sooner rather than later?
Yes, I mean that's that's a great point, Harry. I think that I mean, yes, we'll have to keep things in perspective, of course, because this home monitoring, it's perhaps we have so many challenges even in the UK, whether this is a good use investment. And as you're saying, this current generation of elderly people perhaps are have difficulties of using let's say a tablet or an iPad. But again, having said that, we have to recognize also the benefits, and the potential benefits is that they, especially for people that have severe disease, just having more information, more data, I think that can only help, to detect the disease progression. So perhaps it's not for everybody at the moment, again, because of the logistics and the potential cost. But I think for some people, I think that this could be potentially improving, the detection of uncontrolled glaucoma.
And I think the other thing we mentioned just before was this idea about adherence. And I do believe that education and engagement with patients is one of the most crucial factors in helping them. And I think this concept of home monitoring really does bring the patients, really involves them more in their care. And I think this can only help their understanding, adherence to medications, and engagement with the disease, which is the best thing possible. Because what I tend to find is when patients aren't so engaged, or we haven't had the opportunity to educate them well enough, this is where problems quite often arise. So I think it's a great positive thing for the future.
Yeah, I agree.
And just finally, in terms of the virtual clinics, yes, at Moorfields, we've been running virtual clinics for several years now, and it's an integral part of how we manage to look after our glaucoma patients. And the only interesting observation that we have found is that we're finding that our rates of cataract surgery in glaucoma patients have been a little bit lower in recent years. And we've been trying to understand why that is the case. And our current hypothesis is that when patients are seen in consultant-led face-to-face clinics, there is probably a lower threshold to proceed with cataract surgery than in virtual clinics, where patients may not be so forthcoming about how their eyesight is, or symptoms they may be having. I don't know whether you've had any experience or feelings.
No, that's a very useful. I mean, we have been using virtual clinics, but we haven't been able to capture that because the volume is less than you guys at Moorfields. But what I would also say is that you talk to patients. Patients want to have. I mean, they will. My experience without investigating this formally is that patients are as happy to accept this as long as you explain them and also you explain to them that they can potentially access a glaucoma doctor, a specialist.
Exactly.
But yes, that's a very good point. That perhaps the system doesn't capture some comorbidities and particularly cataract. So that's an interesting and that interesting point. Yeah.
So just to conclude, Augusto, in your crystal ball, what do you think glaucoma care in Europe is going to look like in 10 years' time when we get to 2030?
Oh, okay. So in 10 years' time, not very different. Hopefully, when I'm get a bit old, in one generation, I think there's gonna have, home monitoring is gonna have an increasing role in, certainly in Europe and in well-developed countries. There's no question about it. The apps are here, and we need some, perhaps long-term longitudinal studies and changing practice. I think it's gonna be with us in potentially could happen sooner, but things change very slowly. So I would give it 20, 25 years. And then it will be a very important part of our care.
Okay, well, fantastic. Thank you for a great presentation. Thank you for joining us this morning. Now it's my pleasure to introduce Professor Gabor Hollo. He's the director of the glaucoma service at the Semmelweis University in Budapest in Hungary. He served on the executive committee of the European Glaucoma Society and founded the glaucoma section of the Hungarian Ophthalmology Society. He's published widely and has also contributed to the development of the EGS guidelines. And Gabor is going to be talking to us today about exfoliative glaucoma. Now, before we start, I'm just going to get one or two little polls up again, just to get your thoughts. So the first thing to ask everybody is, do you find exfoliative glaucoma a clinical challenge to look after? Verdict is that we all find exfoliative glaucoma a clinical challenge to look after. And one final thing is, which was interesting for me when having seen your talk, was as physicians, do you discuss systemic associations when you see such patients in clinic, when you make the diagnosis of exfoliation?
So if I understood you correctly, your question addressed the management plan. Did I understood you correctly?
We thought compared to most glaucoma patients, is exfoliation more challenging? And I think everyone did agree this. And
well, I always see challenging cases. Almost all cases are challenging, but the exfoliative cases can be challenging on the long run, no question.
So Gabor, we'll hand over to you. We're looking forward to your presentation.
Thank you. And welcome everybody, and sorry if my technical problems made some disturbance in the flow of this webinar. This time I'm going to speak about exfoliative or pseudo-exfoliative glaucoma, which are identical conditions. There's just different in terminology, and I'm trying to give you an overview of the disease. As you may know, me and my friend Professor Constance were the first who organized and published the very first book, which is fully devoted to exfoliative syndrome and exfoliation glaucoma. We already have 3 editions. They are always updated, and I think it is very useful to everyone who has an interest to this topic to ask for a free copy from one of the educational partners of the European Glaucoma Society, where these books are available. First of all, to start with the clinical presentations, which is the more conventional and classic approach of exfoliation, we address that in our book. And a most important aspect is that exfoliation develops gradually over several years. As you can see, there are different stages, but the real point is that the classic exfoliative syndrome with or without glaucoma, which you can see on the very right, is the form which is easy to clinically recognize. If we go to a true case when the pupil is dilated, you can see the exfoliation material in 3 different areas: the central disc, which is in the middle, where the pupillary area is, the peripheral area, and in between this broken area, which is a so-called intermediate zone. They are due to the movement of the pupilla in normal eyes, which means that the pupil movements simply remove, rub away exfoliation material from the lens surface in the intermediate zone. What you can also see is the exfoliation bushes, which are visible on the pupillary margin. This is easy to see, but it happens only in a small part of the patients. Therefore, pupil dilation is essential. When we dilate the pupil successfully, you can see we have several pigment granules which are attached to the exfoliation material on the lens surface. These granules originate from the pupillary rough, and this is why the pupil becomes moth-eaten-like, which is once again a good marker of potential exfoliation prior to pupillary dilation. The second important point is genetics, epigenetics, and biochemical changes in exfoliation with or without glaucoma. This is a very complex issue. What we all know nowadays is that the background condition for exfoliation syndrome and not for exfoliative glaucoma is kind of genetic deviation, genetic abnormality, single nucleotide changes in the LOXL1 gene, which is responsible for coding the lysyl oxidase like 1 protein. This protein is very important since it regulates several elastic fiber related extracellular material processes in the body. And in brief, the logics for the changes are that the damaged LOXL1 gene due to the single nucleotide polymorphism cause hypermethylation in the promoter region of the gene, which results in a decreased production of the messenger RNA and the later on the production of the active protein. The protein is produced but not in the active form, and this is why in stress situations, mostly in oxidative stress due to sun illumination, elevated high sun exposure, the function of the LOXL1 gene is lost. It is very well documented nowadays that the more time spent outdoors in the young age of a person, the higher probability is to experience exfoliation syndrome later on in the life. This is just one study in which it is shown that the rural to urban ratio of exfoliation in a population is almost 70 to 18, and several other studies showed the same. So actually, what we can recommend to our patient and our patients' kids is to use effective sunglasses when they are outdoors in the sunny periods. The elevated oxidative stress in the anterior chamber, which induces the oxidative stress, also induces an oxidative stress which damages the crystalline lens. And this is why we have nuclear or a dense nuclear cataract in exfoliative eyes with or without glaucoma. This eye looks normal. However, when we dilate the pupil, you can see that this is not a normal eye, this is an exfoliative eye, and you can also see at 12 o'clock position that a surgery, a filtration surgery was made in this eye to normalize intraocular pressure. Thus, this is an exfoliative glaucoma eye. Pupil dilation is essential. However, pharmacological pupil dilation is difficult because the pupil in exfoliative syndrome and glaucoma is purely dilating due to the sticky nature of the exfoliation material. The intraocular pressure, which is increased, shows a large fluctuation, and therefore a single intraocular pressure measurement may not be enough to move our attention from the general aspects to the specific aspects which comprise the potential presence of exfoliation in the particular eye. Due to the poorly dilating pupil, optic nerve head evaluation remains a problem Plus, the patients may have nuclear cataract, and the early form of exfoliation syndrome are really difficult to recognize even by experts. Therefore, diagnosis of this disease is not easy. Whether this is a systemic or a local condition, obviously, exfoliation syndrome is a systemic disease. However, exfoliative glaucoma is very frequently a unilateral condition, which may or may not convert to bilateral exfoliative glaucoma. Approximately 30% of the cases with elevated intraocular pressure and exfoliation show a conversion from syndrome to glaucoma in the fellow eye in 10 years. This is something which we all should keep in mind, because we have to check all these patients regularly in order to intervene in a reasonably early time. We have to measure IOP, and IOP in exfoliative glaucoma, as I mentioned, is usually high, very high, and much higher than that seen in primary open-angle glaucoma. The visual field damage is more severe, than the pressure fluctuation is particularly high. Therefore, doctors in general think that this is a high pressure disease. However, as you can see from the fourth chapter, which addresses the changes of the lamina cribrosa, it is more than that. Because of the LOXL1 deficiency, the extracellular material in the lamina cribrosa is impaired. It is less capable than it is in normalized or even in primary open-angle glaucoma. Therefore, the high pressure and the poor function of the lamina cribrosa together lead to a particularly severe optic nerve head damage. You can see in this study, visual field damage was masked between exfoliative and primary open-angle glaucoma eyes, and for the same visual field damage, the lamina cribrosa damage, as you can see, was significantly more severe for the exfoliative eyes compared to primary open-angle glaucoma eyes for all parts of the lamina cribrosa. This is why natural history of exfoliative glaucoma is so bad. It worsens in terms of visual field damage 3 times faster than primary open-angle glaucoma, and worsens in terms of structural progression 3 times higher than primary open-angle glaucoma. So this is a very rapidly progressing common disease. There are several systemic associations, which I don't have time to speak about. The best known ones are related to the cardiovascular system. In several populations, the associated cardiovascular and cerebrovascular diseases are numerous and they are common. However, by now we know that this is not just a statistical association, it is also a pathophysiological alteration in the vascular function in the small capillary level, muscular vessel level, and the elastic large vessel level. So exfoliative glaucoma or exfoliative syndrome, even without glaucoma, may result in very significant systemic vascular diseases, which cannot be easily picked up since they worsen and develop along the progression, onset, and duration of exfoliation syndrome. Thus, this is not a black and white issue. Less known, but also very important, that in the body where the elastic fibers have functions, the tissues are damaged, and therefore, for example, pelvic organ prolapse is much more common in old females with long exfoliation history than those who don't have exfoliation. And similarly, inguinal hernias are also more common in exfoliative patients than in non-exfoliative patients. Some words about the treatment. Very unfortunately, we do not have specific treatments which should address the oxidative stress in the anterior chamber, the oxidative stress systemically. We have only intraocular pressure lowering modalities. The intraocular pressure using eye drops are numerous. The most efficient ones, based on our recent review, are prostaglandin analogs, prostaglandin timolol fixed combinations, and topical carbonic anhydrase inhibitor timolol fixed combinations. As you can see, they reduce intraocular pressure in approximately 30 to 40%, which is nice, but we have to understand that we cannot expect any well-defined percentage or millimeter of mercury value of a reduction from an exfoliative patient we see, because the reduction is strongly determined by the level of the untreated baseline IOP. Those who have higher IOP show larger intraocular pressure reduction. But anyway, we need very low target pressure, which is difficult to reach with medication in many cases. Recently, urokinase inhibitors may also look as a future potential medication class in exfoliative glaucoma. We don't have knowledge, but there are some minor impressions. In this study, in which a urokinase inhibitor in a never commercialized concentration and formulation was used in exfoliative glaucoma eyes, you can see on the left that intraocular pressure considerably decreased due to the medication, monomedication of this molecule, and when it was stopped, intraocular pressure once again reached back to the baseline level. We don't know too much about exfoliative glaucoma and urokinase inhibitors, but one may speculate that blocking the endothelin-related contraction in the trabecular meshwork, which is very typical in exfoliative glaucoma, the urokinase inhibitor may have or may potentially have some roles in blocking the pressure spikes seen in exfoliative eyes. The conclusion on topical medications is that prostaglandins, PGT molols, and carbonic anhydrase inhibitor timolol fixed combination work best in exfoliative glaucoma. They are effective, but they must be introduced into the treatment regimen early on, because this is a rapidly progressing disease. Since most of the patients are elderly, we should prefer preservative-free medication when available, and we have to carefully monitor the patient's compliance. Otherwise, the patients may progress formally on the treatment. A few words about the laser treatment, which are also very commonly used. We know that the photocoagulative and selective laser trabeculoplasties provide very similar efficacy. Pressure reduction can go up to 35%. This is a very patient-friendly treatment. However, the responder rates decrease along the longer follow-up times after intervention. In many cases, there is a gray time zone where we don't really know whether the patient's pressure is on target or not. And the real problem is that all data are based on office time intraocular pressure measurements, which means that the nighttime pressure, potential pressure elevations are not picked up. So there are several studies which are not yet performed, and there is a need for further investigations. Few words about filtration surgery, which is quite a wide area. My opinion is that the well-performed first surgery should be mitomycin-free trabeculectomy. It is still gold standard. We have data on deep sclerectomy, viscocanalostomy, but there are very few head-to-head prospective randomized comparisons, and therefore we are not really sure about the benefits and the potential costs. Ab-interno trabeculectomy is efficient, but it is not a cheap toy, and trabecular aspiration is also potential. But I have to tell you, since exfoliation material is produced gradually, these interventions may lose efficacy with follow-up, with longer follow-up time. Cataract surgery alone reduces IOP in many cases, probably due to the removal of exfoliation material from the anterior segment of the eye. When it is combined with additional glaucoma surgeries, for example, mixed surgeries, it is particularly efficient, but once again, we have very limited long-term data on the intraocular pressure patterns after cataract or cataract and mixed surgeries in exfoliative eyes. Glaucoma drainage devices are particularly useful, and unfortunately we have to use them in a large number of cases. Cataract surgery and cataract management. We don't have too much time for that, but we have to understand that it is a challenge in exfoliative eyes. The zonular damage due to the increased oxidative stress, zonal lysis, phacodonasis, secondary angle closure when the lens moves anteriorly, damage of lens capsule, they are all factors which increase the complication rate during surgery. But this is not everything. We have to realize that in such patients, we have to go for early cataract surgery before the lens becomes very dense and difficult to remove by phacoemulsification. You can see some clinical pictures, and these clinical pictures shows that cataract can be quite dense in exfoliation. But even if we do a very nice cataract surgery, some years later, the in-the-bag IOL subluxation and luxation is a potential danger. Several studies investigated these problems, and they all found that 1 or 2 decades after uncomplicated cataract surgery in exfoliative eyes, subluxation or luxation of the IOL is particularly common. When we see a case like that, there is a high probability that the eye has exfoliation, and in exfoliative eyes, this is particularly common. This is one more reason why to follow all these eyes, not just for intraocular pressure, but to see whether the IOL is in the original position or additional IOL fixing surgeries are needed. The general conclusion from this session is that current management of exfoliation glaucoma is still intraocular pressure based. There is no specific treatment. We cannot address the increased oxidative stress. We cannot address the dysfunction of the lysyl oxidase like 1 protein. And what we can do is to reach very low target pressure as soon as possible, because this is a fast progressing disease, and we have to control the compliance, we have to control the progression measures, and do additional interventions when it is needed, and we should not wait for long until the next step of the treatment intensification is introduced. While thanking for your attention, I should like to call your attention to the 40th anniversary of the EGS, where we'll have the Congress, hopefully in Brussels in June. And I hope we all will be able to participate. And for those who have an interest, once again, these books are potentially available for free by the educational partners of the European Glaucoma Society. Thank you for your attention.
That's great. Thank you so much for a fantastic overview, Gabor. We got a question from in the panel in the chat box. Would you favour early cataract surgery in PXF, i.e. a bit of cataract but not significant visual loss, considering that surgery will be more difficult when the cataract worsens and might also have an effect of lowering the IOP?
Well, this is not a simple question. If a patient is well controlled on acceptable, not particularly difficult to use medication, and there is no significant cataract, I would not directly go for a cataract surgery. But when the early cataract related minor complaints appear, I definitely would go for that.
And I think the other thing, on the other end of the spectrum, Gabor, what's your thoughts on, we heard from Augusto about telemedicine and virtual clinics. How do you think, what do you think is an appropriate way to manage a patient with exfoliation syndrome, but who has normal pressures, normal fields, and normal imaging? How relaxed do you think we ought to be about monitoring these patients?
Well, whether it is telemedicine or conventional medical controls, in such an easy case, I would go for once a year or twice a year routine control. If the patient is on medication and we have clarified by at least a daytime curve that the pressure is well controlled on a medication, I don't think that we should be more active. Activity may result in other problems in exfoliative patients, and usually, at least in my population, they are not particularly young. In my population, an exfoliative person is never younger than 60. In populations where exfoliation and exfoliative glaucoma appears earlier, of course, more intensive care or more intensive controls should be recommended, but it is very individual based.
And then one more surgical question from Augusto. Do you use capsular tension rings routinely in these cases?
I do not use it routinely, but I use it when it is needed. The reason is, unfortunately, financial. So I have to consider the relatively low reimbursement we have.
Okay. And one thing I've noticed in the pseudoexfoliation population we have in the UK, the condition is usually quite asymmetrical. And I just wondered what your thoughts might be about why that's the case. Why is one eye affected more so than the other?
That's a brilliant and most important question, and there is no answer to that. We do know that the background condition, the genetic alteration, the SNPs, the theoretically, the oxidative stress on sunshine should be pretty much the same in both eyes. I did not mention, but when we go for biochemical changes in the anterior chamber aqueous humor biochemistry, there is a considerable difference between an exfoliative syndrome and an exfoliative glaucoma eye in terms of different proteins up and down regulations and so on. So probably there are additional factors what we don't know. In my population, both bilateral and unilateral cases occur. One has to consider that exfoliative patients peak at two different subspecialty doctors. Those who have glaucoma, they peak at the glaucoma specialist, and those who have exfoliation and nothing and will never develop anything, in many cases, they peak at the cataract surgeon. I myself has a relative who is now almost 100-year-old. He is an exfoliative patient without glaucoma, and he was driving for a whole summer European tour on his own when he was 92 with his wife who had no driving license, happily. So these people do live long, and those who do not develop glaucoma, they maintain very good visual function in many cases, even if they undergo cataract surgery. So probably this is not the same disease. I mean, this is the same background condition, same clinical features, but biochemically speaking, this is not exactly the same disease.
Okay, fantastic. Well, finally, just to finish off, I'd like to thank Gabor and Augusto for two fantastic presentations this morning. Thank you for all of you for taking the time out of your day to join us today. And thanks again to the IAPB for allowing us to run this session, really to focus on Glaucoma Week. So thank you for joining us and enjoy the rest of your day. We will be sending out a feedback survey, which we'd be most grateful if you could complete. And also this has been recorded, so if you wanted to come back and have a look at a few things, this will be available to see online also. Okay, thank you so much, everyone.
Thank you.